Well, welcome everyone. My name is Petherick and I'm a Departmental lecturer at the Blavatnik School of Government. It is my absolute pleasure to welcome Rifat Atun, who's Professor of Global Health Systems at Harvard University. And this conversation is part of a series of conversations about the global response to COVID-19. So welcome, Rifat.
Good morning, Anna. Thank you for the opportunity to join this program.
So I thought we'd start off quite broad and discuss the main reasons for the discrepancies in the capacity of countries to respond to the pandemic. Let's start off with rich countries. What are the main reasons that you see?
Yes, excellent question, and I'm sure for many years we'll be searching the answers to these questions. But what COVID-19 pandemic has revealed is the unpreparedness of countries to such an eventuality or to a pandemic. We knew that there would be a pandemic. What we didn't know was when. And many countries have been running simulations to manage flu epidemics, so on and so forth. But when the moment came, most countries were caught sleeping, unfortunately. And they did not react quick enough. They did not react decisively. And also the evidence base for interventions was very poor. We tried to lay out some of the lessons in a paper we published recently, sort of 12 lessons, which we can discuss later. But I think most importantly, I would categorize the reasons into three main areas. The first, leadership. Leadership was often inadequate. Many leaders dithered. For example, Europe and North America, they had 2 months. We knew that the pandemic was evolving rapidly. We saw what was happening in China, yet 2 months were absolutely wasted. And as a result, we have literally grave consequences of the epidemic in some of the richest countries in Europe, namely UK and Italy and Spain. The second is the interventions that we have. Now, what is very interesting is that the interventions that we use, or we have used, go back to medieval times, to 14th century. Isolation, quarantine, social distancing, hand hygiene, wearing face masks. These were the interventions we were using during the Great Plague. The science has improved, but this part of science has not. And what is very depressing is that scientists, we're still debating whether we should be wearing face masks or not. And we're getting confusing messages. In the early stages of the pandemic, WHO, the World Health Organization, said masks are not necessary. But later on, that was changed. And some countries are using them, some countries are not. So second is, the evidence has been, I would call asymmetric. We have lots of evidence and great science and innovation in many parts, but not in relation to public health interventions. The third is the preparedness of health systems in a broad sense. And many health systems were not prepared, they were not responsive, and they're not resilient. There was not enough capacity, the capacity could not be augmented to reach surge capacity. Human resources were not drawn upon quickly enough. Supply chains broke down, and as a result, we had parts of the system working, but not the system as a whole. But of course, there are other issues that we can discuss.
So it sounds like rich countries aren't really at an advantage when it comes to sort of having extra resources in terms of the behaviours that they want to encourage. But they are potentially at an advantage by just having the capacity of the health system that they could augment more easily. Could you talk a little bit about the differences that matter in health system capacity between countries of different income levels?
Yes, absolutely. So what's important in a health system is that the system needs to function as a system. So one has, and the functions are having good governance and stewardship, good leadership. Secondly, the financing system needs to work. being able to mobilize, allocate resources in an equitable, efficient, and effective and responsive way. Thirdly, the resources, again, must be used appropriately, both physical resources, human resources, but very importantly, knowledge resources. And all of these must be used to produce the outputs in terms of individual health services, but also public health services to improve health, improve financial protection, and achieve user satisfaction. Now, in many countries, not all parts work together, and the system is as good as the weakest link in the chain. So, as parts of the system, parts of the chain were not able to respond, the system as a whole did not respond effectively. So what has happened, for example, is that even in rich countries, even though, let's take UK as an example. The UK has a national health service. There is universal health coverage, there's universal financing. Out-of-pocket expenditures are relatively low, but the governance and the leadership function did not work well. As a result, the interventions were introduced very late. And by the time they were introduced, the epidemic had taken off. And we're dealing with a logarithmic scale increase. So we've been chasing the curve rather than being ahead of the curve. Secondly, in terms of resource management, there was no slack in the capacity, in the system, in terms of capacity in hospitals as well as human resources. So we tried to mobilize those while the epidemic was raging. We were also not able to, and we're still trying to get capacity for contact tracing. UK used to have one of the best public health systems until the government decided to separate this from the health service component of health system. So these resources were not used. Again, the country was not able to put in place supply chain systems and still has not been able to bring on board testing and to scale this up to the level that is necessary. So we can see that every part needs to function to produce the outputs, and as a result, we were not able to indicate context, and we see similar picture in other settings, both high-income and low-income countries.
So I wanted to pick up on something that you mentioned, and that is that countries have been running simulations. Could you tell us a little bit about how useful these have been for planning for the current context and responding to it when COVID has become a pandemic?
Yes, excellent question. So there are two types of simulations. So one is simulating in a mathematical model, and many countries and centers have been using mathematical dynamic transmission models and other types of models to project what might happen with an epidemic, and that then might become a pandemic, to see how rapidly the trajectory changes, what happens to the basic reproductive number, and what kind of systems need to be put in place to manage this. But that's a model, and models have a lot of uncertainty, of course. Again, typically those of us involved in modeling, we say all models are wrong, but some are useful. Maybe that's too harsh a judgment, but models can be useful, but one has to take into account the uncertainty. What really matters is the second type of simulation. This is the real simulation of actually trying to respond to an imaginary epidemic, really testing the responsiveness and the resilience of the components of the system. And some countries go through this process, and the UK did actually have such a simulation a few years ago, and the results have not been shared publicly, and it seems that the actions that had to be taken, the weaknesses that were identified, not appropriately corrected. So it's no good having a mathematical model or a dynamic transmission model that can simulate what can happen, or have a simulation but then not act on it. One has to regularly prepare and test the system. So then when the event does happen, the system is able to move very quickly. The policies are cascaded and elements of the system respond in a unified way.
Is the UK quite unusual in having had this kind of simulation exercise a few years ago, or is it actually something that lots of countries have done?
No, UK is not unusual. I think many countries do undertake simulations. In fact, very interestingly, I've been recently involved with the G20, advising the G20 presidency on their health track, and as part of the health track, some I were run. So this is not unusual, but clearly I think that the logic needs to change. So these simulations, they're not just artificial simulations. One has to run them and say what hasn't worked, what can we do to really improve the capabilities within countries to be prepared when the event does happen. That has not happened.
So I want to go back to something else that you mentioned earlier, and that is your recent article about the 12 lessons that we've learned so far from managing the pandemic. You've highlighted leadership a few times, but which other ones would you like to highlight?
Yes, so decisive leadership is one, and we've seen in many countries that has not happened. Brazil is another good example. Brazil has a good health system, a fairly good health system, but there has been huge differences between the president and members of the cabinet, as well as the governors of different states. In fact, 2 ministers of health resigned within a space of 1 month. So the leadership is important. And linked to that is the transparency. One has to be transparent in terms of the decisions taken, what is happening, and why. And in many countries have struggled. It's very difficult to compare the number of people infected and number of people who have died in countries, because each country is using a different methodology for computing or calculating or estimating number of deaths. And in fact, some countries are not publishing all deaths in relation to COVID-19. And sometimes the reasons for the decisions are not made public. So transparency is really critical. And related to that is effective communication. Again, in many countries, communication has been inconsistent and at times confusing. And we see in many settings, leaders will make an announcement, then a few hours later, another cabinet member will say something different, and then we'll have other experts saying something different, experts working for the government. This is very confusing for people who are not experts in the field, especially when there's a deluge of information. So effective communication needs to be consistent, and it has to be at the highest level. Another important issue is a unified approach, both at country level but also at regional level, what I would call a joined up government approach. And this pandemic is not just a health issue. Pandemic has major consequences for economies, for the social well-being of our communities and citizens, as well as security implications, not least the big geopolitical shifts that are taking place and that will become more prominent as we go forward. So to effectively cope with this, one has to have a unified and joined up response. In many settings this has not happened. So ministries of health have responded, then ministers of economy have responded separately as opposed to having a joined up response. But regional efforts have not been also very encouraging. Let's take European Union as an example. Many of the founding principles of the European Union were not followed. Of course, with the subsidiary principle, health is a responsibility of member states. But Europe has not been able to, or the European Union has not been able to mount a joined-up response with unfortunate consequences, with each country doing something quite different. And 4 months, 5 months into the pandemic, Europe still cannot come up with a joined-up economic plan or a social response. That is not acceptable. Leaders have really failed.
So on that note, there's been a lot of discussion about the strengths and weaknesses of the WHO. firstly, sort of, what do you think needs to change, perhaps about the WHO's role internationally, but also do you think that there should be far more attention on regional organisations such as PAHO and a lot more strengthening of, if you like, the regional governance of health?
That's an excellent question, and the World Health Assembly this week has actually called for not an investigation, but a call for an analysis of the WHO response to the pandemic and to learn lessons from that. Now, so there are two important issues in relation to WHO's role. First, WHO is an international agency, it's a UN agency with the brief for health, but it has no legal mandate over countries. It's not the Security Council. So its decisions, World Health resolutions, they're not legally binding. So countries are able to act, and they do act according to their own needs. What WHO does is to provide guidance, provide an environment for the issues to be discussed, and come up with sort of certain standards, and with technical support to certain countries. But there's only one treaty, one related to health in the world. That's the tobacco framework for the Convention for Tobacco Control. Apart from the framework convention, there are no other legally binding treaties that WHO is able to use. There are the international health regulations that countries have signed up to, but again, these are not legally binding. Well, I'm not saying that WHO should have legal powers. It's very important that countries exercise their sovereign rights, and that's critically important. But it's very difficult for an international organization to come up with guidance that is relevant to every single member state, because a small country's needs, or small island, the needs of a country such as a small island, is very different to a massive country with hundreds of millions of people. So the second issue is in relation to the guidance produced. Coming to this point, it's very difficult to have one-size-fits-all approaches. Therefore, what can be done? First of all, I think there should be greater emphasis on WHO working at regional level, and in countries where support is needed, working at country level. Rather than having headquarters in Geneva, for example, maybe WHO should think about locating to Sub-Saharan Africa, where the greatest needs are, or strengthening the regional offices, regional offices where there are needs. At the moment, resources could be allocated much more efficiently and effectively. Now, what else could be done in relation to WHO role is that is use this as an opportunity to refocus WHO, because a large proportion of WHO's funding comes from not regular sources but irregular budget contributions, which means that countries who are donating beyond the regular budget are able to request on actions or on activities. So as a result, WHO is doing too many things. So this is an opportunity to focus on a few things and do them really well and go very deep, as opposed to trying to do far too many things without appropriate level of resourcing or capacity. And clearly a pandemic response must be one of these core functions. So decentralization, and then creation of a lean organization that is highly focused on a few tasks would be beneficial to WHO and to all of us, of course.
Fantastic. Let's talk about something that isn't discussed nearly as much as the WHO's role right now, and that is global insurance systems. Could you explain to us what the main ones are, and how do we actually make them fit for purpose?
Yes. Well, as far as I know, there's only one major instrument that has been used, and these are the pandemic ones, which the World Bank developed, which actually were used to pay number of countries that used the instrument. But again, the sums were not very large, and also the triggers that were used were quite onerous. So by the time the triggers were and the thresholds were reached, the countries were very much into the pandemic. So as a result, the impact may not have been as positive as it could be, and secondly, the disbursements of the funds were delayed. But nonetheless, this could be a useful instrument. For example, not just for poor countries, but also for richer countries to think about developing such instruments for insurance, and maybe as part of that undertake a very detailed analysis of health systems to check system responsiveness and resilience as a way of identifying potential risk, so that one can use sort of risk-adjusted sort of premia for countries when issuing sort of insurance when issuing bonds, and then for each country the bonds could be used to generate funds when needed, not just for the health sector but also for the economy and for the social sectors, because this is where the big problems are going to be going forward. The unemployment levels in all countries are reaching levels we've never seen before, far greater than what happened with the Great Depression. And the question is, how are countries going to meet those needs? So one has to think of innovative financing solutions to develop series of bonds, perhaps, for health, for pensions, maybe for the economy.
And you've actually got me thinking that there are these kind of innovative insurance solutions emerging in the area of climate resilience, for example, among Caribbean countries. So maybe a series of poorer countries could pool, if you like, their resources in this way.
Absolutely. I think that's an excellent suggestion, given the earlier discussion we've had on regional responses. Again, with a pandemic, the chain is as strong as the weakest link. So maybe one could develop regional or sub-regional responses or sub-regional pooling. For example, in the sub-Saharan African context, there could be SADC or Eastern Africa or Western Africa. And similarly in Asia, one could use ASEAN or maybe other platforms that currently exist to create regional and sub-regional groupings to develop meaningful instruments that are highly context specific.
So a lot of what we've been talking about is really data dependent. And I know that you've written before about the need for a revolution in global health data. Could you say a bit more about what that means in this context?
Yes. This is. I think this is one of the major problems in global health. Many countries and many international institutions hoard data. Data are not available in a timely manner. They're not available in a comprehensive way. And this really delays the potential responses, because one is not able to understand what is going on. And this is not acceptable, especially international institutions hoarding data, because they're funded through taxpayer money. The data should be public goods available to everyone. So the data can be analyzed, different questions can be, for different questions to be posed, and for different analyses to be undertaken to provide an understanding of what is going on, and also to develop responses and to measure the effectiveness of these responses. So I wrote an article once called Liberating Data that relates to a study which we were trying to do, where we were not able to get data that was held by an international organization. So we had to go to each country and request the data individually. That took a full-time person working for about 18 months to get the data and to clean the data. Now we have a great collaboration across many countries using this data, but very valuable time and resources were wasted. whereas these data could have been made available. And it's the same in relation to the pandemic response. It's very difficult to get primary data to really understand what's happening in countries, so that one can understand the nature and the extent of the magnitude of the problem and the effectiveness of the responses that have been introduced. And that hinders response. It also hinders innovation. So maybe something that WHO or the UN can do is to have a treaty on making data available, including the data that they hold.
I can absolutely speak to that. I've been trying to run models with data about how health systems have been augmented since January, and there's nothing that I can find available. And it's really important in trying to give advice to governments about the tendencies that we see.
Yes, and also to understand what has worked, what has not worked. And I've been trying to do the same with a country that I'm advising, but also at regional level. And in spite, in one of the papers we've just submitted, it took a number of the authors are very senior people. It took weeks to try and really understand what the responses were. So that's a real challenge.
Let's talk a bit more about how health systems, supply chains that feed health systems have been breaking down. What has really been the problem here? Yes,
so there were two major issues in relation to health systems, in relation to supply chain mechanisms or supply chain systems. One is the international supply chain systems. For example, certain countries were the predominant suppliers of inputs to many of the products that were used. Once those international supply chains were broken, it was very difficult for the downstream activities to take place. And so one has to think about developing sort of capacity and resilience, or maybe some buffer stocks for some of these critical ingredients that need to be used, say for diagnostics or for medicines or personal protective equipment, for example. And have multiple supply chains, so not relying on just one, not just one that sort of dominates in relation to a particular product or particular service. Secondly, the intra-country supply chains also broke down, and we saw this in many countries in relation to food, as well as supply of health products. There were huge delays. All of a sudden, the demand increased, and the supply was not able to meet the demand, and also the institutions involved in the value chain, in the supply chains, were not able to augment the capacity at every step of the supply chain. As a result, we were not able to get the products to individuals or the services. Again, going back to our chain analogy, all the elements in the value chain or in the supply chain need to work simultaneously, effectively and efficiently. If one element is not working, then the supply chain will not work. So as part of the earlier discussion on testing the responsiveness and resilience, a critical component of this must be looking at the resilience and responsiveness of supply chains in responding to such external shocks, and the ability of these supply chains to introduce to enable availability of core or critical products.
So to do all these things self-evidently requires health ministries to coordinate with other ministries. And I know that you run a program at Harvard where you teach many ministers. What do you teach the health ministers in particular?
Yes, it's been a real privilege actually to be involved with the Harvard Ministerial Leadership Program. I act as the faculty chair, and it's one of the activities I very much look forward to every year, where we hold an immersion program for ministers of health in June, and for ministers of finance in April, following the the World Bank and IMF spring meetings in Washington, D.C. Actually, with Ministers of Health, we'll also now include in the training Ministers of Education, but also Ministers of Development. And what has emerged, we've been running the program for 8 years, and we're learning constantly. And ministers challenge us all the time. They're a wonderful group to work with. And what we've learned increasingly is the importance of having a joined-up response, and the importance of leadership. So the focus is on identifying important leadership traits that enables a leader to be effective, what the kind of actions one needs to take to ensure one is able to discharge leadership responsibilities and duties. Secondly, understanding how to prioritize, because there are many competing issues a minister has to deal with. So how does one prioritize? What is the process? Who decides? How? What are the mechanisms used for this decision making? What instruments are used to come up with a set of priorities? And then translating these priorities into set of actionable points that can be developed over time. And for this to happen, we focus on two main instruments. One is the budget. How can budgets be used in an effective and efficient way to allocate resources to reach those reach the targets or goals of a particular priority? And secondly is implementation, in having a clear strategy and implementing all the activities that have been decided. Because in many settings, there is even if the priorities are identified and plans made, these are not translated into action. So there's real implementation failure. Much of the effort goes into policy analysis and policy making, but not policy implementation. So it's a very practical course that enables the ministers to think through the issues specific to their context, then come up with strategies which they can implement with the priorities identified. Then they're provided support. Actually, many of our students from the Harvard Kennedy School, Harvard School of Public Health, and Harvard Education School go to countries to work with the ministers to help them implement the strategies that they have identified.
Well, you must be pretty busy right now on that basis. Yes. On that note, and really as a last question, when it comes to setting strategy and prioritization, when you strip those decisions back, fundamentally there's a lot of ethical questions that arise. What kind of conversations are you having with your alumni who are health ministers, or what do you expect to have at the next training session that really get to the nub of this kind of ethical dilemmas that they face?
Yes, excellent point. And again, most important is for everyone to understand there isn't a single right answer or a single solution. The solutions generated are very context specific, and ministers or the government as a whole need to take into account multiple factors. First of all, the values of the society that are reflected in the government. What are the priorities of the citizens of the society? And these vary. We see in some countries health is put first. In others, people want their individual liberty and the economy to open up. But these are societal views that need to be taken into account. The second is the institutional setting. What is the capacity of the country, of the institutions to implement a set of priorities? The third is the technical considerations. What interventions are effective or cost effective that can be implemented? And fourth, and very importantly, is what are the current and future needs? Then all of these need to be combined to think about the priorities, but then have a very clear and transparent process for priority setting to ensure that the process is inclusive it is replicable, it is flexible if the evidence changes or if the views change, and the results are communicated to everyone so that everybody is on board. So it's not just a whole of government approach, but actually a whole of country approach to setting priorities. And we see this interestingly in Portugal. There was a very strong push by the citizens to generate a response. So Portugal was, as a result, it's been one of the more successful countries in the European context to develop a whole of country approach to the pandemic, going beyond what the government could do.
Wonderful. Professor Atun, thank you very much indeed.
Thank you very much.